So progressive overload is making sure, yes, you need to overload in one single stimulus, but that for continual adaptation, the overload must be progressive and the dose must increase. So what does that mean? How can you increase dose? Think about it for a second. So we can increase it by changing repetitions. We can change the amount of time. So you could do 3, maybe you start with planks for 3 sets to 30 seconds. We can increase that to 3 sets for a minute. You can change the load, which is kind of the easiest one to think about, and then you can change how many sets are being done as well. Variety, I love this. It's such a good take-home message for us right now because of how many of our youth are doing year-round sports and how many of us maybe pick a certain exercise style and stick with that. Really for optimal adaptation and to avoid stagnation and overuse and injury, the stimulus must be varied and the variety must allow rest and recovery, and this will actually show to reduce injury. So if you think about some of the common training programs out there, what do you think about certain training programs that are going to cause the most injury? I can think of one of my biggest referral sources at our clinic is the CrossFit gyms, and it's a high intensity and it's a really high volume that they're doing repetitively, but also take into account that the variety is with gymnastics, which a lot of people and a lot of the general population have not grown up doing in that certain manner. You can also think about a little bit easier consideration would be thinking about year-round sports for our youth athletes, so maybe swimming year-round or playing baseball year-round and volleyball year-round, and then you're getting into college and collegiate level volleyball players seeing a lot of injury because of that and a lot of poor scapulothoracic rhythm. And so just things for us to consider and how do we educate them. I just evaled a gymnast 10 years old who's had severe hip pain for 3 months, and she still goes to practice. On Friday night, she goes to practice for 5 hours, and the rest of the week she goes to practice between 2 and 3 hours a week. So not a lot of variety in her routine, and a little bit hard discussion to have with the patient and her mother. Rest is one of the key things. We talked about this a little bit earlier in the first section, but rest is really optimal adaptation requires rest period to be interspersed with our training sessions sufficient that the adaptation caused by exercise can actually take place. So we have a deformation curve that occurs, and if we don't allow enough rest, then we're actually moving into the negative, and we'll move into that quickly. It was pretty cool. A study done by Bishop et al. In 2007 looked at the rate of recovery and directly correlating with higher training volumes. So showing that with a proper amount of rest, training volumes and intensities would really do extremely well, and you could reach a high peak of training volume and intensity. But without it, there were significant detrimental effects into overtraining. So that's a good conversation to have. I was treating a competitive Olympic weightlifter, and he was plateauing, and he was starting to have some adrenal fatigue symptoms, which really mimics overtraining and is overtraining. And so it was a conversation about, when was the last time you actually had rest? Do you cycle through that? He had just come off of the games competition, and so a lot that goes into it. And so thinking about that and trying to make sure that we're looking at that patient holistically within that. And then thinking about rest-wise, acute phase of rehab, we're going to have to incorporate probably, what do you guys think? If you go into a patient's room, they've just had a total joint, or let's just say that they're in there for some other type of injury or pneumonia, what are we thinking about with rest periods, and how are we incorporating that? Are we incorporating supersets or back-to-back sets of exercise? No, we're probably going to make sure that they're performing exercise, and then they're resting up to 2 to 3 minutes. Recovery, goals of recovery, really thinking about, we have 4 really main goals for recovery, and we can compliment Jeffries in 2005 and his colleagues to really come in and hone in on this. So first one would be normalization of the physiological functions. So recovery would be that our blood pressure returns to normal, our cardiac cycle, our respiratory rate, those all return to normal. Second would be that we start to see homeostasis coming back into that resting environment return as well. The third would be that those energy stores are restored. So blood glucose and muscle glycogen are restored. And then the fourth would be that replenishment of that cellular level energy enzymes. That's when we're talking about phosphofructokinase, and it's really that key enzyme in carbohydrate metabolism. Really, we want to just consider that this, in addition, the recovery is very dependent on specific types of training. So we might just need to take that in consideration. If you look at a triathlete, their training is a different stimuli in most case scenarios. And so where does their rest come into play with that? Or are we looking at someone who's doing 2 a day training sessions, and are they getting enough rest in between? Or is that kind of the norm and what they need to do to make sure that they can do their job or their sport or their recreation like they need to do? Rest between sessions. This comes up quite a bit. So key components to really look at is, what is the stress of the workout? Are we stressing multiple muscle groups at one time, or are we just focusing on maybe a specific muscle group? Is there risk of damage or soreness? And so if there is, we might need to prolong how many days in between sessions we have. And then, of course, we're always looking at that starting status. Are they beginner? Are they elite? What's that look like? And what's the typical volume that they're used to doing? Was the volume drastically increased, now creating some of that? We typically want to see 48 hours in between a muscle group being trained. And those are our bigger global muscle groups when we think about that. So understanding that we might need to train postural muscle groups in a different way, but our big global muscle groups, a lot of the research shows us that 48 hours really is a good key factor for that. Okay, let's move on. Reversibility. It's basically saying if you don't use it, you're going to lose it, and understanding that it's all reversible. And so we want to make sure we keep exercising. I like this graph quite a bit. It shows that there's training taking place, and if we stop, we're going to see detraining occur. And then, but if we start during that detraining to retrain, we can actually still go on to that that really nice recruitment and mitochondrial content. So we have the ability to really go in cycles if we need to. One study showed that atrophy in a hospital setting occurs within 3 days' time, so it can happen very, very quickly. We want to make sure that we're addressing those deficits, trying to prevent those. Maintenance. This is kind of a interesting concept to me, and maybe to you too as well, but current fitness levels can be maintained by exercising at 1/2 to 2/3 of the volume. Isn't that's just crazy? We can reduce the volume, but keep the intensity the same, or we can reduce the intensity and keep the volume the same. So you can train harder, you can shorten your workouts to maintain the fitness component that you're at. Now, it probably needs to have a little bit more research done behind it, but just thought that was kind of fascinating that once you reach a certain fitness level, you can still maintain it without going as hard and as heavy. Ceiling effect, this makes sense, right? Genetically, we're probably predispositioned to do that. As fitness increases, just understanding the relative and absolute improvements in fitness will decrease, even with a continual overload. This is a great picture. This is a standing vertical jump. It's 46 inches. Gerald Sensabaugh, I think is his name. So some of you guys will probably know that better than I will, but pretty phenomenal what we can achieve and what we put our minds to. For the longest time, the mile, right, we couldn't break the 4-minute barrier. And then once it was broken, now makes it a little bit easier to do that. We know that it's a law of diminishing returns with exercise, so we'll see that as a person who hasn't exercised or is unfit, they'll see changes really early on, but they'll max out, and then those changes will decrease. Same phenomenon. Interference. When training with several components at once, the stimuli may interfere with each other, slowing adaptation down in one or both of the components. So meaning if I want to be an endurance athlete and I want to be the strongest man on the face of the planet or woman, that I can't have the best of both worlds. Can I be good at it, and can I probably compete in certain arenas and be really good at that? Yes, absolutely, but I might need to figure out what my ideal desire is and goals are. The FITT application, dive into this a lot deeper into the ACSM guidelines, and use this along with the 10 movement variables to create a program specific to the patient that you're treating right in front of you. So each component of fitness has ideal training, right? How often would be our frequency, intensity is how hard, time is that duration, and rest intervals taking into account of that, and then type. So which mode are we going to talk about? We're talking about cardiovascular fitness, neuromotor fitness. What are we doing with that? Our strategies really are those key ways. It's our plan of action on our part on how to really make a big grand design. So what's our strategy with our patient manually? What's our strategy therapeutic exercise, home exercise? So what are we doing with that patient, and how are we going to get there? So here's just a few strategies for you. It would be first and foremost, start with success. So as you talk to your patient, you're going to ask them what position they prefer, and you're going to start your treatment in that position. You'll do some manual interventions that way. You'll do some therapeutic exercise that way. This really helps your patient decrease their fear avoidance and helps you be more successful with what you want to do with that. Think global and act local. So that means if I come in and I'm pointing to the lateral aspect of my right knee, you're going to act there, and you're going to act there first. But as you start to design a plan for them, you're going to think globally. You're going to understand if they've had previous surgeries. You're going to understand if they're a desk worker. How does that affect that, and how are you going to make sure you incorporate that? If they have extremely poor posture, what are you going to do to ensure that that's not hindering your outcomes and your goals? You're going to unify the treatment sessions with the goals. So incorporate your patient into that discussion. That will make it much more desirable for them. If you're progressing or regressing, do that with a certain set of exercise, but keep in mind what your goal was. So if I look at someone and I say they need glute max strengthening, I don't always have to do the same exercise for that. Maybe it's a squat, or maybe it's a posterior lunge. I can mix up the exercises to target neuromotor or some, just to keep it maybe a little bit more interesting. But then I can think about, I'm still targeting that same muscle, so I'm unifying that recruitment of the glute max is going to help them with their walking and with their going up and down steps, but I can change the way in which I go about it. Tweakology, we just want you to know what this, because you'll hear it from us. This just means you're assessing, you're prescribing, you're reassessing, and you're tweaking. You're constantly tweaking. So if I watch someone do an exercise and it doesn't quite look the way I want them to do it, I'm going to tweak it a little bit, meaning I might verbally tell them to change position. I might tell them and use a driver to change it. I might give them an external task to do to change it. So just understanding as a PT, this is a way in which we are constantly involved with the program, and then understanding that we're going to try to keep our patient involved as well. This is really key to helping your patient be the most successful. And what I would say differentiates your patient walking out saying, oh yeah, I did physical therapy and I got 75% better, between that and then now my patient is significantly better and they have strategies to do at home because you've tweaked it to be specific to them. We're going to incorporate that psychosocial presentation. So guys, what does this mean? What does that mean to you? If you came to me at the very beginning of your PT career, and week 1, how did you feel? Week 3, how did you feel? Week 6, how did you feel? Week 12, how did you feel? Imagine if you were going into a rehab setting at each one of those, how would that have affected your ability to participate, to heal, to get better? So remember, a lot of our patients have a lot going on, and it's, some of it is maybe their pain, but there's a lot of other aspects to our patients that we need to be able to identify and to work within and work around that. We're going to target Mostability. So this is a Gray Institute term, a Gary Gray term, and it's knowing that you want mobility, but you want stability within that mobility. So let's just say that I spend a lot of time and get you all this new range within your ankle. And your ankle feels really good, but it almost feels unstable because your body has used that restriction as stability for a long time. So I might do a manipulation of your ankle, I might do some joint moves and some soft tissue work. And if I let you leave out the door, then I'm actually doing you a disservice. Because 1, I haven't trained the proprioceptors how to protect you. 2, I haven't trained the muscular fascial system how to really act now because of that increased mobility. So just remember that. We want to kind of always bridge those two together. Movement techniques. So this is where we come in with our specific techniques. It's the skills that we're going to have our patients do. It's those specific exercises. And these come back to thinking about what we talked about in the very beginning. We're looking at neuromotor control, trying to gain symmetry as best we can. We're looking at motor planning and fluidity, reaction and speed. What do we do? What are some of our techniques? Well, we have a lot in our toolbox. We have our therapeutic exercise. We have other interventions like dry needling, cupping, kinesiotaping. We have our manual therapy techniques. Those are very wide variety, from soft tissue to mobilization with movement to IA-stem. And then we have modalities or alternative modalities. So a lot of different things that we can do. We're trying to always come up with more tools in our toolbox, and the goal is actually just to have everything you can to try to help your patients and help their impairments, help improve their function, and ideally enhance their health and wellness. How great is that? I just read a study that no state in the United States of America has less than 20% of the population having overweight BMI. So meaning that the state of Arizona has 25% of the people are considered overweight or obese. And it's pretty sad. I think the southern states like Alabama, there were 4 southern states that have 35% over the 35% mark of the BMI. It's pretty crazy. So let's just enhance people's health. Let's help them get to where they want to be. It's not necessarily innovation. It's being thoughtful, making sure you're tweaking and you're looking at the patient response and you're making a unique approach. And so don't just treat every low back pain patient the same. Let's make sure we're making it individualistic. Elements of progression. You're going to progress. Increase the frequency, intensity, or duration. Typically, you're going to do 1 at a time. For our older patients, we might choose time. That might just be also dependent on what type of muscle you're using and recruiting in your end desire. So if I'm doing a postural muscle, I'm probably going based on time because I want that to be a prolonged, sustainable hold where it's active. And then if I'm doing a bigger global muscle, like the deltoid, I want that to be a strong muscle. When it's needed, it's acted upon. is a good just stage of progression and thinking and taking into consideration where we're at. So initial conditioning stage, improvement stage, and maintenance stage, and breaking it down. We know that within the first 6 weeks, that's a lot of neuromotor training. It's not necessarily even changes at the muscular level. And it's really where we're probably going to start with our lower to moderate intensity. So you're not going all out super heavy the first time, because that's a big risk for injury. And this, we're going to probably increase duration, and then we'll start to increase load and frequency. Making sure that we're doing that kind of 10% rule, not increasing more than 10% every single time. This is a stage that can be skipped if you've got people that are coming in that are active. The improvement stage, 4 to 8 weeks. So that rate of progression really occurs rapidly. So sometimes we would just say it's at 28 days to make a habit. So you've reached your 4 weeks, you should start to see some really good changes within the body. We're looking at a systematic increase in frequency, intensity, and duration. So try not to do it all at one time and really be considerate of that. And then that maintenance phase is preserving the desired level of fitness, making sure that we're really looking at what the patient should be doing, really according to the ACSM guidelines, and getting them to that stage. And then if they have other goals, helping them with that as well. It's just pretty crazy. 1 in 2 adults in the U.S. don't meet the ACSM guidelines and recommendations. 1 in 4 report no physical activity. And within 1 year, 50% of adults drop out of an exercise program. I worked at Lifetime Fitness and was a trainer all through PT school. I was a trainer in undergrad, and that's how gyms make their money, is because people sign up and then they pay their monthly fee and then they don't come. So really kind of sad thing. So understand what's the factor influencing that for your patient, and how are we really going to go at improving that. I like this warning. Exercise has been known to cause health and happiness. So just kind of a nice subtle thing to give ourselves and our patients, and that nudge we all need sometimes. These are really the behavior modification models and health belief models, social cognitive models, and this is for improving adherence. You guys will dive into this a lot more in some of your subsequent courses. Just really good to understand different things that might help us. So different ways we might incorporate our patient into goal setting and developing a plan. We might use some rewards like, oh, when you graduate, you get a t-shirt. We might help them with understanding what's the benefit and do you want that benefit? So I'm going to be able to do that. So that'd be that health belief model. And then what's that social cognitive model? So where do their beliefs lie in that task, and what's their confidence about making a change in that behavior? And can we be a positive influence in that change? We absolutely can. There's just different areas where they're at, that pre-contemplation. I just met a lady at Coffee Bean, and she said, oh, are you studying to be a physical therapist? I said, funny, I'm actually a professor. And she said, oh, my mother, she just went to chiropractic care, but I love PT so much more because I have MS. And so we talked about that there is a value in chiropractic care and there's value in PT. But she said her mom didn't like to go to PT because the therapist made her exercise. So where is she at in this? She's contemplating preparation, but action is not happening, right? And definitely maintenance is not happening. So this is just another way to understand where we're at, helping people weigh the cost-benefit ratio. People all know that exercise is good for you. That's why I really like to come back to, we don't always need to drill this in during initial eval. We can work this in as they start to feel better in your programming with that kinesthetic learning. They'll start to buy in and want to exercise more. So just look over those, gloss over those. Good for you guys to understand that, and these are good strategies to help you with how to motivate patients while you're trying to get there. This is also really good to know the self-determination theory. So where does your patient lie in that? So amotivation, really no intention or desire to exercise. Like they come in and basically say, I am not exercising no matter what you tell me to do. Which is always hard for a physical therapist because we feel like we don't want to We're not there just to please them, right? We're there actually to be their medical guide and to really show them what they need to do. The other determined motivation, so maybe they're motivated by outside factors, guilt, fear, maybe pressure. So think about maybe some adolescent girls feeling pressure to look a certain way, but maybe that kind of lack of internal want or need. And then self-determined extrinsic motivation. So that would be that you value exercise, but we're really motivated by extrinsic factors. So how do we look? Maybe there's a certain health or gain in fitness that we're going after. And then that intrinsic motivation, really that really sheer enjoyment and satisfaction it brings and that well-being it brings. So taking a look at these and just categorizing your patients, and they might not always fit in a specific number or category. They might be in a continuum throughout that, and we all are, right? We all are at some point in our life. How do we motivate them? So these are kind of our tips. Move to a value motive. So really tie it into what they really want to do. Let's get them there. Let's help them get them there. Create opportunities for competence and success, meaning let's make it meaningful, and please celebrate that and celebrate the successes. Don't overemphasize trivial accomplishments. I can't tell you how many times I catch myself saying good and it's not good. The repetition wasn't good. Maybe the effort wasn't good. There's just something that doesn't make it good, but that's kind of our right? So try not to do that and really focus in on things that are meaningful for them. Create opportunities for autonomy. So really, what does this mean? Maybe giving that respect to your patient of when they are making correct choices and they're avoiding really poor choices in their health. We're trying to avoid coerciveness and controlling engagement. And I tried really. I think I didn't really take this into account as much when I was an early PT, and now it's so much different when you have some time under your belt and experience under your belt, and just knowing that there are certain ways and factors that how you present yourself are going to influence your patient, but ultimately it is up to them. And the more that we give them to do at home in a successful manner, the better they're going to be. And then lastly, create opportunities for relatedness. So giving an example of proper desired form, and then always end the right way. I had a patient tell me one time, Tammy, I love that you show me the right way and then you show me kind of the mistakes that are being made, but then I have that in my head and I don't have the right way. So what a good take-home message. And so I want you guys to apply that as well. So end on the way you want them to do it. Okay, guys, you did a great job. Take-home message. Remember, there's really no bad exercise. It's just poorly prescribed. So taking away that there's a lot that goes into it, and you, as long as you're thoughtful and you are analyzing movement in the best way and to the best of your capabilities, and you're striving for a very healthy patient in multiple ways, you guys are going to be very successful.